Hello, I'm Elliott Antman, President of the American Heart Association. We're here in sunny Barcelona for our AHA Science News. We're at the European Society of Cardiology Congress. I'm delighted to be joined by Dr. Rose Marie Robertson, our Chief Science and Medical Officer at the American Heart Association.
And welcome to everybody who's watching. Well, I'm really pleased to have the opportunity to have Dr. Elliott Antman give us his opinion on the trials that were presented today at Hotline II here at the ESC. So, Elliott, let's start with something solid, the solid study. So this was an interesting study, I thought, because of its background. The concept that we could do something to reduce the incidence of plaque destabilization is really, would really be, if not a Rosetta Stone, certainly a paradigm shifting, not to talk about yesterday in the paradigm trial, but would certainly be a huge advance in our ability to change the course of events for patients with coronary artery disease.
Absolutely, Rose. It's a very interesting question. We know that acute coronary syndromes are believed to at least be in part a result of inflammation in the coronary arteries. So the hypothesis here was whether the use of a drug, daraplatin, which is an LPPLA2 inhibitor, essentially blocking the cascade that leads to destabilization of plaques, would be effective. And there was reason to believe that this was worthy of investigation because in some phase 2 studies, there appeared to be a halting of the progression of the development of enlarging necrotic cores of atherosclerotic plaques. So there was actually a program that was developed that actually had 2 trials, the stability trial, which had patients with stable coronary artery disease, and then the solid TIMI 52 study that had more acutely ill patients. They had an acute coronary syndrome and were enrolled in the study within 30 days of that event.
And so the idea was that if we've been able to show, as we had in the phase 2 studies, that the necrotic core didn't continue to enlarge, with the presumption that an enlarging necrotic core leaves you with perhaps a thinner fibrous cap, or at least a more vulnerable plaque,
yes,
something that would be more likely to lead to further unstable symptoms. That if we could reduce that we ought to be able to make a difference. And this, pretty acutely ill patient subset ought to have been an ideal group to look at that.
Absolutely. And daraplatin was compared to placebo with respect to its ability to modify the primary endpoint of cardiovascular death, myocardial infarction, or urgent revascularization for acute ischemic events. This was a null trial. The curves are virtually superimposable, and there was really no evidence or even a signal of benefit with daraplatin in this study that followed patients for just about 2 years in the post-ACS situation.
You think that's the end of the story for this drug? Or?
Well, it's a very interesting question. We actually have null results from the stability trial, now null results from the solid TIMI 52 study. It's going to be a challenge to find a way to move forward with further investigation of daraplatin, but let us hasten to say that there is no reason to throw out the inflammation hypothesis for coronary artery disease just because this particular approach didn't work.
A point that you've made in the past is that, and that we recognize, is that atherosclerosis and the progression of events, these are long-term processes. And do you think 2.5 years was enough?
Awfully hard to know. Looking at the Kaplan-Meier curves, they were virtually superimposable for the entire course of the study. There wasn't a suggestion that the curves separated at a year or a year and a half, and we'd only followed the patients longer, we might have seen a different result. Would the result have been different if, in fact, the patients had been followed for a decade? That's hard to know, and we're in a position now where with these 2 studies that are really null, it's hard to think of a way to move forward unless some additional analyses uncover something that we just haven't heard about yet.
Okay. Well, let's talk about in our list of studies beginning with S. Let's talk about SIGNIFY. So here we have a study of idrabidine So this is a drug that had very nicely shown a decrease in symptoms in patients with stable angina. But let's say, to begin with, that here's a drug that blocks the IF current, the pacemaker current in the sinoatrial node, so that we get heart rate reduction, but without a change in ventricular function. So unlike beta blockers, we don't see some of the other effects.
No negative inotropic effects.
Absolutely.
Right.
So here we have just a decrease in heart rate, maybe not just, but that's the primary effect. And so symptoms went down in stable angina, and in fact there were outcomes that were better in heart failure patients. So I suppose following along the concept that reducing heart rate in those patients, as we do with some beta blockers, is beneficial for patients with heart failure. And given that, it seemed reasonable to do a trial that would look at outcomes in patients with stable coronary disease.
Yes.
And what happened there?
So the foundation that you were referring to is the SHIFT HF, or heart failure trial, where there was improvement in the patients who were randomized to ivabradine. So the SIGNIFY trial looked at individuals who had chronic angina, stratified by their Canadian cardiovascular symptom class. And it turned out that the ivabradine therapy compared to placebo on top of well-administered guideline-directed therapy had no impact on cardiovascular death or MI. There was a disturbing observation in patients who had class 2 angina or worse. Those individuals actually did worse with ivabradine compared to placebo. That's a disturbing observation. We don't know why it occurred. The authors speculate in their simultaneous New England Journal publication that perhaps the heart rate was lowered too much, or there may be an additional effect of ivabradine that we just don't know about and we need to learn more about. I imagine that the results of the SIGNIFY trial will cause the clinical community and perhaps the regulatory authorities in those countries where ivabradine is currently approved for use to take a close look at the results of the SIGNIFY study and determine what impact it might or might not have on the current labeling for ivabradine. The United States is not one of those countries where ivabradine is approved, and we'll have to see what the implications of SIGNIFY are for those countries where it is approved and how it might impact any considerations in the United States.
Yeah, it is disconcerting. Here was a trial that one might have expected to actually broaden the indications for the drug, and in fact this may narrow it since, you know, if the idea was to use it in patients with stable angina to improve their symptoms, and that it worked quite well in that regard. Now we have to wonder if those symptoms are activity limiting. That really was the group that had problems. If the angina is activity limiting, this might not be the best choice, but we'll need to see what happens.
There was a very sound rationale for moving ahead with the SIGNIFY trial. Of course, that's why we do research. This was an unexpected result. We can't cast it aside. We have to understand exactly why it occurred in this population of patients and what the implications are.
And your point's a very interesting one, that even with a drug that we think we understand quite well and know what it's doing in the body, there can be things that we don't anticipate that produce some other outcome. So that's why we do these studies. So let's then look at the Odyssey trial. So there was a cluster of Odyssey trials here. It seems to be part of the ongoing saga of the PCSK9 inhibitors. We're very proud of that. Helen Hobbs is the investigator who is a distinguished scientist of the American Heart Association, received some of her funding from us, and so it's been quite exciting to see a whole new class of drugs come out in our ability to lower cholesterol.
Yes,
tell us about those?
Sure. And kudos to Dr. Hobbs for actually opening our eyes to the possibility of inhibiting PCSK9 as a potential therapeutic avenue for patients with hypercholesterolemia. This set of 4 trials evaluating aliricumab are the next chapter in the ongoing story of PCSK9 inhibition, which is a very, very encouraging one. Virtually everywhere we look, we see a result of a trial with a PCSK9 inhibitor that lowers LDL quite significant, perhaps 40–50% reductions in LDL to ranges that we just can't achieve with conventional therapy with a statin or even in combination with another lipid-modifying agent. And the way these PCSK9 trials are organized is they evaluate patients with a variety of conditions where one would be very aggressive in reducing cholesterol. For example, familial hypercholesterolemia, heterozygous familial hypercholesterolemia, individuals who have hypercholesterolemia that is not adequately managed with a statin alone or a statin in combination with another drug, for example, ezetimibe, and in following these individuals over the long term. So in fact, there were 4 trials with alirocumab, and they all had very positive findings about the ability to reduce LDL quite significantly. The way these drugs are administered is by subcutaneous injection. Depending upon the agent, it's either every 2 weeks or every 4 weeks. And I think about this as a coronary artery disease patient or a patient with hypercholesterolemia giving themselves an injection, much like our diabetic patients give themselves injections of insulin. As with all of these new approaches to managing hypercholesterolemia, the question arises as to whether or not they translate into a benefit for the patient in terms of reduction of heart outcome events, cardiovascular death, MI, stroke, etc. If I were to speculate now, seeing these very striking reductions in LDL, I strongly believe that we're going to see some significant reductions in outcome events. We just haven't seen the results of those trials reported in yet, but I'm quite optimistic about the whole field of PCSK9 inhibition. And I imagine that when they start to report out, specifically with respect to heart outcome events, our guidelines writing committee members are going to be working very hard to see what the implications are for our guidelines on managing dyslipidemia.
Oh, absolutely. You know, initially when these drugs, when these agents came out, and the concept that you had to inject them was part of the picture, you know, that seemed as though it might be a limitation. But in fact, you don't have to inject them very often, and of course, people do use insulin daily, sometimes multiple times. And so it doesn't seem a great barrier, particularly if you think about groups like familial hypercholesterolemia, where, you know, the group that got, on top of, you know, fully approved treatment, had a rise of 9% in their LDL, as opposed to a 45 or 50, 49% reduction with PCSK9 inhibitors. So yes, really dramatic.
So, Rose, lots of very interesting data that are coming out here at the ESC meeting. It's been a pleasure chatting with you about Hotline II.
Terrific. And we'll be back with more from the European Society of Cardiology later on this week.